I mean, this would have been a great topic for actually a debate, but doing Jugalbandi is going to be a challenge. But we thought that we will try to see how we can make it more interesting. Okay. Well, it's a hot topic. Chennai is hot. Manoj, you are looking very hot. Okay. So with that, let me ask this burning question that people are really asking for. Myth versus reality. Now, can you explain this? People want to know, is it a myth or is it a reality? Can you explain this?
Sure. So, well, morning everyone, and pleasure being here. And thanks Dr. GVK and team. And a greater pleasure this Sunday morning doing Jugalbandi with Dr. Aravind, one of my mentors. Coming back to the topic about myth versus reality. Well, so the myth is that once a diabetic, always a diabetic. But what's really changing is the fact that today we are realizing that this can actually be a reality as well. So in the early stages, we do understand that diabetes can be reversed if diet and exercise are taken care of, and largely you are able to reduce weight through different means.
Okay. Now, the problem we have is the wordings, reversal versus remission. I mean, what's the right term? Because
I think that's a great question.
Lot of talk goes on about this.
Right. So, what's the right term? Now, if I said the reversal is more charismatic, a word. Reversal is something which catches the eye more. Reversal is more attractive a term. But the right term actually is not reversal. It's something which you use when the condition is completely cured. Can any of us say that diabetes with its pathophysiology can get completely cured? Less likely. So the term remission actually applies, because the fact is, in many cases, even if there is remission, then this can come back if the individual gains weight because the fact that beta cell function is going to gradually deteriorate. Sometimes you have your parameters normalizing because of weight loss, calorie restriction, exercise, great lifestyle. But you're only in a phase of remission, and there's always a chance that it comes back. So to use the term reversal, I think is more commercial and a little pushy. Remission is the right word, similar to what we use for cancer.
I think this is a very nice thing that you put it up there, that the beta cell function also deteriorates over a period of time.
It does.
So initially it's the weight loss which reverses it, or remission. But over a period of time, when the beta cells actually deteriorate, you can still get back diabetes. Because see, this is what we have been told, I think, after this particular thing. Very interestingly, Manoj, what happened was, I wanted to Google and then see. You just put down the word diabetes reversal, and I mean, you don't have to read this. I don't want the audience to read this, but the important
can
thing
you
is,
still explain to me that number?
point.
No, I want you to explain that number. What does all those zeros?
0.39 seconds. This is the number of hits, whatever it is, 57 crore, 10 lakhs,
somebody here will know their math, no? Can somebody tell me what is that? Lakhs, billion, million, those numbers?
This slide is just to tell the audience that that's how popular this term has become, diabetes reversal. And we must thank COVID for this. And no, this is the Google. No. I mean, Google
it's
search.
Search engine.
Google search. No, I'm not searching. So many people are searching for the term diabetes reversal. So anyway, diabetes is metabolically reversal, at least for a period of time. Now, important, your own slide said that we know about this. The beta cell function deteriorates over a period of time. So even if you lose weight, reversal is possible, but at some time you can always get back the diabetes. Now, Manoj, for the audience, let's put it very simply, okay? What is this reversal? Because see, there is hyperglycemia and there is normoglycemia.
Right.
Okay, many patients ask the same question. Does it mean that I'm already on the medication? Can I stop all the medications? Can I just go back to diet and exercise? And if you have to say reversal or remission or whatever it is, what should be this HbA1c? Is it less than 5, 6.5? Should it be more than 1 year, etc., etc.? So I think you have made some slides. Now,
Sure.
you can start with this.
I think that's a great question to begin with, because very often people come to us who are on medications and their HbA1c is 6.4
Yeah.
or 6.3, and they say that, is my diabetes reversed now? But if you're on medications, you don't call it a remission. So what is the definition or criteria for remission? That if your HbA1c is less than 6.5% and you're off medications, now that's when the definition comes in. So you have different criteria, different this thing, but if you're off the drugs for at least 3 months,
3 months.
and your A1C is less than 6.5%, that is when you are said to be in remission. Now there are other terms which are defining in terms of how long the remission lasts, and there will be data which is supporting in terms of from studies which is at the end of 6 months, 1 year, and longer as we'll be able to show ahead. But simple definition is off medication, A1C less than 6.5%, off medications for at least 3 months' time.
3 months, okay. So what you're trying to say is it's possible with the combined effort of
diet and
whatever this
exercise plan
diet and
to achieve
exercises.
this.
So
Yes.
that is still the integral part of diabetes management, right? Okay, so you can sum up the slide because you spoke about reversal and remission.
So when we talk again about coming back to the question reversal or remission, so let's remember that diabetes is a chronic disease. If the measures used to achieve normal glycemia are not sustained, then the diabetes comes back. And that's extremely important, that whatever efforts are done, and today everybody is looking at remission or in their own minds reversal, but the efforts need to be sustained, because there's again otherwise always a possibility of the weight and the hyperglycemia to come back. Even if the weight loss is sustained, hyperglycemia can resurface, because as you showed earlier, the progressive decline, or what is also called as the Starling's curve of pancreas. That slide which Dr. Aravind showed, I think that's something that all of us should use when you have your first conversation with an individual newly detected with diabetes, that look here, do what you may, but the fact remains that the beta cell function is going to deteriorate, and that's something which should be guiding therapy and decisions ahead as well.
I think, Manoj, from what we have learned now, it's basically that you kind of put on weight because of the 10 cycle hypothesis. This is what we have learned in the pathophysiology, and then there is also the personal fat threshold. Just to take the audience back just for a minute, I'm sure the next session is going to be talking about hepatic, pancreatic fat, etc., etc. But I'll quickly take you through the concept of this. Basically, it's overnutrition. We have to remember it's overnutrition. When there is excess of calories, more than what the body can handle, there is going to be a de novo lipogenesis. So that means there is going to be accumulation of fat on the liver, insulin resistance develop. Initially, there is additional insulin production, hyperinsulinemia. Now, at some stage, if there is going to be more and more calorie intake, more fat than what the liver can handle, now this entire thing shifts to the pancreas. So there's going to be more of fat on the pancreas. And then there is less of insulin coming out of the pancreas. So it starts with insulin resistance, more fat on the liver, then it shifts to the pancreas, and you end up developing diabetes. But when you lose weight, the concept is this entire thing gets reversed. I think the next session will discuss more about how the fat accumulation actually has an effect on the liver, increase in free fatty acids, and so on and so forth. So we have to remember type 2 diabetes is a disease of overnutrition, positive calorie balance, and interestingly, each person has their own level of liposusceptibility, and this is very interesting. And there is a potential to reverse independent of the BMI. So even a person with a normal BMI, when he loses weight, there is a potential to reverse his diabetes for some period of time. Because we know as the weight increases, as the BMI increases, the chances of getting diabetes also increases. And we also know from this cartoon that a person who is overweight He can also be looking like a normal BMI person but metabolically unhealthy. When he loses weight, the reversal happens. So when once the insulin resistance drops, hepatic fat levels comes down, pancreatic fat level comes down, from hyperglycemia, he can move into normoglycemia and he can continue with his diet and exercises. And there have been a lot of strategies, okay? So I think I will leave that to you, the evidence and the strategy, Manoj, because we have to quickly finish. Diet, exercise, weight loss of more than 15 kgs, what is really necessary and what is the evidence that we have for this?
Sure.
It's exactly. So now that's a good question he has asked. Okay, what should be the weight loss for reversal?
So
What is happening? And
let's look
what
at the
should
data.
we tell the doctors? What should be the minimum weight loss for this?
Okay, so let's look at the data as to what has been done in the major studies and what they have really achieved. Now, you have evidence for remission through bariatric surgeries, through low-calorie diets, such as 600 to 800, and then you have low carbohydrate, which essentially means less than 50 gram of carbs per day. Now, what bariatric surgery procedures? Essentially, the Roux-en-Y gastric bypass or the sleeve gastrectomies. What they have shown is actually initial type 2 diabetes remission rates going up to 80% in some of the published data. What about long term? Because let's understand that post bariatric surgery or procedures, there is significant weight loss and remission. But what's important is how long do patients remain in remission, and hence the long term data is important. So long term data shows at the end of 5 years, there's 30 to 40% patients in remission. From an initial 80%, by the end of 5 years, it comes down to 30 to 40%. And that's what we're trying to even show here. If this is the pointer, yes. No, I can move it, but I'm trying to go back. In terms of the different procedures, you can see the sleeve and bypass right there showing the maximum results. Then you have the low calorie diets, and then the low carbohydrate diet and the low calorie diet on top. Let's look at the evidence through some of the studies. The counterpoint study, which actually used 600 kilocalories of liquid diet and some non-starchy vegetables. So over the last several years, there have been different attempts by different researchers in different parts of the world trying to use different means of calorie or carbohydrate restriction. And some of them we will show now. So this is a small study, 11 patients, 600 kilocalories diet with non-starchy vegetables for 8 weeks, and they achieved a 15.3 kg weight loss. So to the previous question asked about kgs and percentage be scientific, in this particular study, it was 15.3 kg, which was 15 to 20% of the body weight lost. And there we see the results in terms of fasting plasma glucose plummeting down in the initial weeks and sustained. You look at the hepatic glucose output coming down, and similarly the liver triglyceride content coming down and being sustained over the week. So this was the counterpoint study. Then we look at another one, the counterbalance study, which was again a small population, 30 patients, diabetes duration between anywhere between half to 2.5 years. 800 kilocalories per day was what was offered. Again, 8-week study. Weight loss, 15 kilogram average with 40% remission at the end of 8 weeks. The follow-up period at 6 months, 43% still continuing to be in remission, and remission persisted in those individuals who had no weight gain at the end of 6 months. And that data again for fasting sugar, A1C and weight is shown on the right side. So again an interesting study, both these studies telling us that the crux of it is about 15 to 20% weight loss. In most of these studies, this meant absolute numbers about 15 kg. What about the more popular study that everybody hears about, the DIRECT study, which made Dr. Roy Taylor a household name in the diabetes fraternity, at least across the world. 306 type 2 diabetes patients, duration less than 6 years, again 800 kilocalories. So the larger mantra and message of remission comes from this word of 800. So if you remember some of these figures, it's 800 calories, it's causing 15% weight loss or 15 kg. These are the ones which have shown successful results. 1 year remission, 46%. 2 year remission, 36%. And the recent released data, those staying in remission at the end of 5 years continues to be 23%.
Yeah.
Study done in UK, largely by family physicians or general practitioners, which form the main base in the NHS system. They were involved in supporting and motivating patients to stay in this trial. Of those still in remission at 5 years, average weight loss was 8.9 kgs, and that's still continued to offer them the benefits.
I think we can actually skip this. I'm sure the next people are, or you can quickly say it out.
So the chairs are informing us. I think the next speaker is delayed, so we actually have some time for this.
You got some more time to explain.
I think the important thing, Manoj, from what I've realized from what you said is, weight loss is absolutely important. It's individualized. Despite diabetes going into remission, some come back and then go into this mode of hyperglycemia over a period of time. And it's almost impossible to predict who will actually go back to the hyperglycemic state. So it's not just the weight, there is also an individual variation, and different studies have been.
Can I deviate from this, doctor?
Yeah.
Right. So, while we are discussing this and having a discussion on remission, and it's all about weight loss, does this apply only to individuals who have a higher BMI? Now today, in India, a lot of individuals will be lean diabetics. If they lose weight, one, they will be afraid to lose weight. The families will make them change the doctor that, you went to them with 60 kgs and today you are at 52.
And what is the percentage of the weight loss you will get it in a
lean individual, and whether that leads to, so is this only restricted to individuals or on the heavier side?
I think even with people with a normal BMI, when they actually lose weight, their diabetes also goes into remission, because there is a difference in the threshold of the fat in every individual body. Okay, I think we missed the slide because we thought that Krishna and others are going to speak.
In that case, do you have an account for the visceral adiposity or?
Yes, there's a different threshold.
Yeah.
Before diabetes, after diabetes, and whatever may be your BMI, if you lose weight, then it becomes easier. And important thing is, the amount of weight loss necessary for remission is totally different from amount of weight loss necessary for good control. So when people lose 3-4 kgs under good control, they are very happy. 90% of the people go into that category. They don't want to lose further weight. You need a lot of motivation at that.
And what is that partial remission and complete remission?
There is no partial complete, but then the definition is only 3 months HbA1c less than 6.5. So, I mean, the whole idea of this, the concept came because we have to now motivate our patients to lose weight. Now, by coming out with the word remission and things like that, it motivates them to see that probably they will exercise better and then lose weight.
If I can just add to that, it is about the duration. So it's not, it's when are you using those terms, whether it's 3 months, then at the end of 6 months and 1 year, then when you're using those terms about not really partial.
Yeah.
But if you can go back to that one slide, because I think this is important that
I think we'll go back.
Yes, the factors of success. So for everybody here.
This is the one,
Yes. So if you want to tell what really are the factors which make one succeed in remission.
I think it's a degree of the weight loss, at least less than 5 kgs of weight loss, remission in about 7%. This is based on the studies and the data and statistics. More than 15 kgs weight loss, remission is seen in a higher number of percentage of patients, 86%. And the duration of diabetes is extremely important. You just mentioned about it, because over a period of time, your beta cell function keeps coming down. And even if you lose
the best
weight,
chance is within 4 years of diabetes?
First 4 to 5 years. I think first 4 to 5 years from the onset, where you think your beta cell function is good, I think your chances are going to be high.
In addition to the duration, it is also the degree of control. Even if you have 1 or 2 year diabetes, if you are poorly controlled, then remission is not possible.
Correct. So I think that's a point very well taken. And of course, the baseline beta cell function is very difficult to measure in clinical practice. We don't do this. Baseline hepatic and pancreatic fat, I think there's going to be a lot of discussion in the next
So,
talk about
to your
it.
point, Dr. Arvind, baseline beta cell function, that means today, a lot of individuals in the first few years of diabetes, seeing any of us here, are very keen, and the question is, because there's so much of remission, reversal, you open Facebook, you open any of that, and it starts flashing, that everybody thinks of that. Does that mean that we all should be doing C-peptide levels right in the beginning for our patients?
C-peptide levels will only tell us about the amount of insulin that is getting produced. It's just an indirect mark of insulin production, not the beta cell function at all. So I think this was also tried by many researchers trying to do C-peptide. It hasn't really helped. HOMA.
So HOMA beta, but that would not be clinically
The problem is in
possible at the
clinical
clinic level.
practice, you cannot do HOMA C. I mean, that's
You
the
can
problem.
do C-peptide, but the issue with C-peptide is going to be that you need serial C-peptide. It doesn't, it will change again, as you said, with the level of, so there is evidence now that again the C-peptide will change if the patient, how many years, degree of hyperglycemia, insulin usage and so on.
Yeah. So I think next one is the conclusion.
So that's my slide, okay.
Yeah.
So type 2 diabetes, to conclude what the message we are, and then we open it up for discussion, is a potentially reversible metabolic state caused by excess intraorganic fat. And that's where it's important that even when we talk about a lean individual in the Indian Asian phenotype, there is clear evidence through the thin fat Indian concept that this normal or lower BMI individual also has a lot of paravisceral and intra-abdominal fat, which is what is contributory. Why does the liposusceptibility change in individuals? Well, there are individual variations which is responsible for this. Remission can be achieved with a negative calorie balance and substantial weight loss. And that's extremely important for any of us who tries to give a diet, whether it's a physician, a nutritionist, dietitian, diabetes educator, that always get first into the history. You know, in the past, there was this concept to start with 1200 calories, 1400 calories. It never worked. So first get the recall from the patient, how many calories he or she is having, and then try and achieve some amount of minimalization, cancellation on a weekly basis, but with the fact that you want to do a negative calorie over a period of time. Of course, all these studies started very drastically, and because that was supported and a lot of hand-holding that bring them down to 600 or 800 calories. Long-term remission requires continuous effort, motivation and support, positive mindset, socio-environmental factors. So a lot of social support for this. Anybody in a family trying to do this requires a lot of support. Whatever physical activity possible, stress management, good sleep are all the new mantras for a healthy metabolic life. So diabetes remission is a reality, not a myth, as long as we understand that these have been achieved in people and what are the factors which lead to success, but it's not something that everybody can achieve or the way it tends to probably get projected. That should be the message again to everybody, that it is a reality, not a myth, but very, very specific reasons lead towards this remission.
Do you got any criteria to choose which patient will go for remission? Therefore, choose that type of patient, then put the patient on remission.
Well, I think it was clearly made, you know, preferably newly detected or the first couple of years of diabetes, somebody who is overweight by 15, 20 kgs, if he's motivated enough to follow the diet and exercises, if he can lose 7 to 10 kgs in the first 1 year, I think he's a candidate who can go into remission. But the
Duration of
problem,
diabetes.
less than 5 years, preferably less than 5 years. Known duration, of course, you never know the real duration of type 2 diabetes. Known duration at least less than 5 years. If somebody can lose 10 to 12 kgs, he can go into remission. But the problem is the motivation. Indian food is so lovely, people rebound, and there is a yo-yo effect always that happens.
Sir, wonderful presentation. And as per the ADA recommendation that is proposed, the 3 definitions. One, partial remission, that is HbA1c less than 6.5, complete remission less than 5.7 for more than 1 year, and prolonged remission, that is more than 5 years, maintain the HbA1c more than less than 5.7 by more than 5 years of prolonged remission. As this is a nicely metabolic disease of remission in the exacerbation, like, disease, infectious disease, bronchial asthma, exacerbation, remission, like that, diabetes is a remission exacerbating disease. But the question is that here is, you have a high caloric restriction. If you take 2000 calories per day, it will give us a 15 milligram of iron per day, which is only 10% absorbed for iron. If you restrict to 500 to 600 calories per day, the iron content is itself very less. It is 1000 calories, only 6 milligram, 10% only is absorbed. So like that, if you restrict to 600 calories per day, how much of iron will be there? That's because already the iron deficient area.
I fully agree with you because
the diet what they have provided in the British, they take into all the micro, macro nutrients and give the diet.
correct. So
Therefore,
these
they don't
diets
go
were
into
well
the
balanced.
malnutrition, etc.
They were expensive. It's very difficult to replicate the kind of diets that were given in these trials with the availability of the food. And hunger is something it's very difficult to manage. It's always told, anger, hunger, desires. Three most difficult things that we all need to conquer. And as long as there is hunger, our Indians don't really take this up.
There's one more question, is that one more question? One more question.
Type 2 diabetes. That is diabetes.
In type 2 diabetes who are not put on any medicine, oral anti-diabetic, anything, from the day of diagnosis, put them on early insulin and treat to target, how long it will cause remission?
Sorry, is your question about early insulin use in newly
Insulin in
detected?
virgin diabetes.
So I agree with you. Again, in terms of wherever this has been used, newly detected type 2 diabetes, hyperglycemia, HbA1c above a certain percentage, these patients given insulin. So the data has shown even when insulin has been used for 8 to 12 weeks in such individuals, giving rest to the pancreatic beta cell, overcoming glucotoxicity, I think these are the individuals where we have seen without the calorie restricted means, in terms of even if you don't follow that path, the individuals who change their lifestyle to whatever extent, those who've gotten insulin in the beginning for a few weeks have the best chance of remission. How long that remission lasts is very, very individualistic. So it depends again on how these individuals carry on, how motivated they are to take this ahead. So again, we have that, sir. So what will happen? All of us, all of us will have our own case studies that I have some patients here, some patients there. Unfortunately, this has not been an organized study, but yes, all of us will have cases and anecdotal cases.
The important thing is, I think there are two things here. One is normalizing hyperglycemia will not lead to remission. Okay, we have to be very clear. Weight loss leads to remission. Okay, you can start with insulin, normalize hyperglycemia, HbA1c is normal, you can take him off insulin, you can take him off drugs. But will he really go into remission? No, you need that weight loss. Okay.
Sir, in this aspect, I was associated with Twin Health for the last 2 years. Same findings what I have observed. So only cooperation from the patient family and our team, nutrition coach. These are all people who are involved in the control. And what we have seen is only remission, not the reverse. We are seeing only remission. And we are warning the patients, if you will continue the same diet and exercise, it will be prolonged. Don't expect miracles after 1 year. Again, if you are eating normal food and without exercise, you will come back to normal. Because we should remove those, because Facebook and other things, they are creating sort of the noise about total reversal. Total cure is not possible, only remission for some time, as long as they are particular individuals following the principles.
So I think the message through this conversation also has been to understand, let's not use the word reversal, remission is the right word.
Yeah.
Also claims made sometimes through bariatric surgery as diabetes reversal surgery and so on can be questioned, because even post bariatric surgery, patients achieve remission, not all, some of them, and then we've seen the data what happens. So the right term is remission, and encourage those who can achieve and maintain it, it's wonderful.
Yes, oh, nice that we listen to a general practitioner and a general physician. Unfortunately, I don't know, the only endocrinologist left the scenario. Okay, then I'll shoot. Okay, see whether the term remission or reversal. There is, of course, reversal is, I see, right, remission is the right term, but there isn't much difference. Okay, it's a dynamic process. Okay, so you have to be very careful when you disclose this to your patient. Because patient shouldn't think that, oh, it's like a cancer cure, I had to pong up and we are not quacks. So this has to be, tell them that this is, in this stage, at the moment it's fine, but you are a diabetic or a potential at least. That is the thing, and the concept is old. It's, at that time it was from IGT to full-fledged diabetes. It's a dynamic, it can go to this way or this can go to this way, provided you institute appropriate lifestyle measures, maybe metformin. And this transit time is roughly 10 years because the gradual fall in the beta cell mass. So the message is that we are all ignorant about the beta cell biology and we are all illiterate about the way to measure the beta cell. Ideally, we should
Any
bring
other
people.
Questions?
What question? You sit down.
Any other questions? Yes.
So see, this is not a general practice. This is a specialty term. So we have to bring the specialist or basic scientist who can give us the how do we predict the decline of the beta cell mass. That is the sure way of informing the patient. This is like a cancer la avanga FNAC பண்றாங்க, then genetic எல்லாம் பண்றாங்க. நம்ம கிட்ட அந்த tool இல்ல. So நீங்க எல்லாம் ஸ்பீக்கரா இல்லாம உட்கார்ந்து you bring the right people, then the hall will be full, the message will be clear. But ideal candidates are we. If a medical graduate is an IGT person, he will be the right educated and motivated person only alone can, because this is a wonderful opportunity.
The chairperson, right? Are we done?
We'll wind up.
Right?
If we'll wind
So
up.
when you general practitioner have 10 minutes, I should have 12 minutes. Listen.
Go and
okay?
contact the organizer, sir.
Go and
contact
we
the
are the
organizer.
organizers, okay? What you did in Indore, this is Tamil Nadu, we are the organizers.
Go and contact the organizer. Don't call us.
Stop giving lecture to a specialist. That is the message.
Dr. Manoj Chawla, one last question. You have put so much of efforts to make up this wonderful lecture. This is a personal question to you. The simple thing, the most simplest question, diet, exercise, lifestyle modification like Dr. Aravind told, anger management or other things, how would you rank them in the order of importance, and maybe if you can approximately give a percentage?
Can I tell you that?
The priority.
Can I answer that question?
Yeah, sure.
I think diet is 70%.
Yes, agreed.
Diet is straight away 70%. At one time, I can tell you from my own experience, right now I stand at 80 kgs. I had gone up to 96 kgs, and even 1 to 1.5 hours of workouts and gym and things that did not work. Diet down by 10 kgs within 6 months. Sustaining the diet is difficult. Taking a nutritionally balanced diet is different. You have as many festivals, as many functions as the number of days on the calendar in India, and somehow you get tempted. I think it's the diet. I think it's mainly the diet.
Aravind, I think when you ask the patient to lose weight, they lose the muscle mass.
Yes.
I think what is important is that the sarcopenia, the sarcopenic diabetics, when the muscle mass goes down, the receptor number comes down, so your glucose uptake will not be there. I think one should teach them, when you lose the weight, it's a purposeful weight loss, you should lose only the fat mass, not the muscles. I also teach my friends do at least 10 minutes of isometric exercises.
Perfect. That's the right answer. I think
That
strengthening exercises,
let us be
resistance.
always, you simply say it's a 15% weight loss. They may not know what weight to lose. It's very easy to lose the muscle mass rather than the fat.
So I think that's why some hand holding, whether it is coaching, hand holding, all of that is important,
Very important.
both for the muscle aspect
I think
and for the
that slide should be
micronutrient
included,
supplement.
for the practitioner's sake, that the importance of maintaining the muscle in a diet.
Muscle mass, strengthening exercises, resistance training, I think all these becomes important. As you said, I think it's literally hand holding, and it takes about 45 minutes of the effort of a dietitian.
This
to
Rai Taylor gave a shake and soups. What's the diet actually? It was shown us. That's what the message says.
Sorry?
Roy Taylor,
Uh-huh.
in his direct study, he has
Shake
given
and soup
shake
diet.
and soups.
Yes.
I don't know what is the soup he gave, what is the shake he gave.
So again, these are starchy vegetables, what they have used soups, they have used a lot of protein shakes in that.
That could that also could be better. What he has used, we can also take a Indian analog of what exactly could.
So that's what we
substitute.
probably, my question would have been that we probably need to see a similar aspect being done here. So we have data from Roy Taylor, we have data from different studies, but here we have shorter data. You have individuals in different clinics across the country who have the 20, 30, 40 patient data, but nothing which is organized and do that. Krishna has also some data.
If it's balanced diet.
If you look at if you look at a careful data, not necessarily.
Yeah.
So even in TDR, caloric restriction actually is protein sparing after 8 to 12 days. So up to a time of 6 months, caloric restriction does not cause muscle wasting. If there is muscle wasting, there is something else going on. So I think we need to be, while you should be using exercise to build up muscle, but muscle wasting itself means that there is some other pathology going on and it's not due to the caloric restriction. I think that day, I'm sorry I barge in, but this is something important.
Absolutely right. I think it's to share the information. I think.
Again, the insulin resistant originates in the fat. Only the fat, that especially the visceral fat class, that can give you more insulin sensitivity. Of course, muscle is out, but fat I think is the main culprit, as he rightly. But we need both all the exercise. That is why swimming.
Thank you very much, speakers, for a wonderful discussion.